Defecogram, or your ART may call it an evacuative proctogram for a fancy term, all right? Or a Defeco for short. One of the things on all of the board reviews is they call it a functional study, so underline that, okay, of the anus and rectum during the evacuation and rest phases of defecation. Most common clinical indications are rectoceles, rectal intussusception, or prolapse of the rectum. Defecography, or evacuation proctography, it's a test that shows the rectum and anal canal as they change during defecation, having a bowel movement. This test is used to evaluate for disorders of the lower bowel that are not evident by tests such as colonoscopy or sigmoidoscopy. Defecation, it's actually a complex action. It requires coordination with relaxation and contraction of a large number of muscles, controlled by the nervous system, but it is also under voluntary control. Your healthy, normal functioning person, defecation is a voluntary control, okay? Setup, what should you do? Initially, you're going to start with the table down, but with the footboard off. You are going to draw up 3 of these 60 cc syringes, the catheter tip ones. You're going to use this barium paste to put in there. I want you to watch for air bubbles when filling these syringes. Okay, when you're putting that into the patient, it's going to give a big pop if you have any air bubbles. Make sure you take the cap off prior to putting it on, okay? Lubricant, just like you would need for a BE tip and the balloon pump. We use the Defeco Make sure you have a red biohazard bag covering it, and then cover it with a sheet until you're ready for it. When I was first hired, we used a caulking gun instead of the syringes. So it literally made the clicking noises to get it into the patient. It was some sort of special. So you're going to do it really similar to a BE, Sims position to place your tip in the rectum, and then you're going to inject the syringes. This is not easy, and it takes some muscle. So be prepared. You're going to be surprised, actually, how hard it is. So we use this almost identical chair here, all right, with the Defeco and the nice steps. You're going to slide that right up against the bottom of your fluoro table. So you're going to inject into the rectum. The patient climbs off of the table. You stand the table up, and you place this Defeco chair right next to that table, okay, and they're going to sit on it. So, similar to that of the BE, make sure your radiologist is around or close by before you tip. I always go find them, look into their eyeballs, and say, are you going to be here? I'm going to tip my patient for the Defeco. Put a DVD into the DVD recorder. Patient in Sims position, place the tip in the rectum. Place the patient in a true lateral, call in the rad. You're going to inject 3 of those 60 cc's of barium paste into the rectum. They will take maybe 1 or 2 shots under fluoro just to check and see where they're at. Remove the tip. Ask the patient to try and hold in the contrast. Get the patient off the table. Stand the table up. Place your commode in position. Have the patient sitting on the commode. Please cover them with a sheet. Try and make them more comfortable. This is a totally awkward thing for them to do. So just cover them with a sheet. Try and make them relaxed. The images that the rad is going to take are going to be in a relaxed position. Then they're going to ask them to squeeze. And then they're going to ask them to push without evacuating and then evacuate. Make sure your rad or your resonant is on multiple frames per second before they do this, if you could do a quick check. So the patient is resting, straining, push but don't go, which is the hardest and most confusing for most people. And then post-evacuation, they want them to push it all out until they think they're empty, see if they have any residual. All right, this was a nice one for anatomy. Common conditions, chronic constipation, rectal prolapse, rectocele was an outpouching of the rectum, fecal incontinence, and anismus, inappropriate spasm of the anal sphincter, rectocele. It's an anterior or posterior bulge of the rectal wall. So kind of either this darker pink area here, posterior or anterior. It's usually because of a weakness somewhere in the rectovaginal septum. At the end of defecation, they may have contents that are left in the rectocele, so it might be trapped, and then they can't actually fully evacuate because it's trapped in that. Similar to that of like a diverticulum, right? They're found more often in female patients, usually the female patients that have had natural childbirth and kind of push some babies out. They may have a feeling of incomplete bowel movement, usually because it's trapped in that rectocele. So the rectocele bulging is right here. Right? They're evacuating out, but see this little indentation here, and it's pushed forward. Intussusception of the rectum. Intussusception, we know, right, is a telescoping, so it can happen of the rectal wall. I don't think this is a super common thing that happens, and we don't see a ton of this, but they have difficulty in bowel movement, pain, with some blood loss possibly, incontinence, and mucus discharge. So you can see indentations here and here of the area, and basically this image here is showing you how it's sort of telescoping in. An enterocele is the peritoneal sac that is herniated downwards along the ventral rectal wall. Okay, so pushing down and out here with the green. It's not supposed to be, right? There's grade 1, grade 2, grade 3, depending on severity. Sigmoidocele. It happens commonly in female patients with constipation. They have a lot of increased pressure due to pushing out. And with constipation, it has a higher percentage of patients that have had a hysterectomy compared to females that have not had a hysterectomy. But sigmoidocele is a prolapse of redundant sigmoid colon. All right, it's less common than the enterocele. Spastic pelvic floor syndrome is a persistent contraction of the pelvic floor. All right, it's a functional disorder of the pelvic floor muscles causing an outlet obstruction. MRI. So your patient, sometimes they have had an MRI defecogram as well. So it's increasing in popularity versus the our regular X-ray defecogram because it has multiplanar possibilities, right? So it can do different slices and get sort of a more detailed image. But for your patient, sometimes going an MRI is difficult for them, right? If they are claustrophobic, anything like that. So it is a lot longer of an exam than ours, but it's also used. So these images are from an MRI defecogram. Look how extremely detailed they are, right? Okay. Fun facts. Defeco, fun facts, if there are fun facts about defecograms, right? Symptomatic pelvic floor disorders are common in women, occurring in about 24% of all women over 20 years old. It's higher after childbirth, increases with age, and obesity. Pelvic floor disorders are relatively uncommon in men, but it may occur. A lot of times it's after radiation treatment or surgery for prostate cancer. So you may get a male for a defecogram as well. Internal rectal intussusception, enteroceles, sigmoidoceles, rectoceles, or the inability to relax the muscles can result in constipation due to outlet obstruction. All right, these patients prescribe straining during at least 30% of defecations and often experience a sensation of incomplete evacuation. They may have to use manual maneuvers to facilitate evacuation. So don't be alarmed if your defecogram patient who has history of constipation uses a manual maneuver in your room to be able to evacuate the contrast. Review your anatomy, all right, pelvic area anatomy for me, okay? And I think that's it for Defeco.